Good afternoon. I'm Rick Pollock, President and CEO of the American Hospital Association. Thank you for being part of our first virtual executive forum. You know, it seems like first virtual describes practically everything we've done this year. And although we can't be together in person, the important thing is that we're still able to talk, to share ideas, to share best practices, and to recognize the terrific work that you and your colleagues are doing in leading the nation's hospitals. You know, every year brings its challenges, crises, and fire drills, all of which test our leadership. And this year has been unlike any other, as our nation faces an unprecedented public health crisis, coupled with an economic crisis, and the need for our nation to squarely face up and address the issues related to social justice stemming from systematic racism. In the midst of all of this, hospitals and health systems as cornerstones of our communities have a special role to play as we focus on hope and healing. We've seen how hospitals and health systems have been islands of stability among all the chaos and confusion over the past year, in particular, where anyone who walks through our doors, regardless of their political persuasion, ethnic background, race, religion, or sexual orientation, is taken care of. All of you continue to provide essential healthcare services to the best of your ability, where every single hospital in America is truly a safety net organization. And hospitals and health systems continue to step into the gap, where many of our organizations have become the de facto public health agencies for their communities, given the government's failure to adequately support those entities, leaving that infrastructure in a dilapidated condition in so many areas. To all of the caregivers, from the doctors, nurses, respiratory therapists, and pharmacists, to those who clean the rooms and bring the food and secure the buildings, we all owe you a debt of gratitude for your hard work and dedication in protecting patients and caring for communities. It's been a team effort, from the corner office to the back office to the boardroom. You are truly all healthcare heroes. You know, for us at the AHA, our vision is a society of healthy communities where all individuals reach their highest potential for health. These words guide us in what we do every day. To achieve that vision, we must address racial, ethnic, and cultural inequities, including those that are in healthcare, that are everyday realities for far too many individuals. Clearly, communities of color have been disproportionately affected by COVID, both in infection rates and in the economic impact. Even before COVID, you're all too familiar with the statistics and about the problems that we face in this area. Now, while progress has been made, we have so much more work to do. As a nation, we need to take this moment to hold up the mirror and honestly take a look at ourselves. Then we need to engage in the hard but necessary work to make fundamental changes and address our society's inequities. We need to develop and implement real solutions to make a genuine difference. Our country must right these wrongs so we can build a more just and equitable society where every individual has the opportunity for success. The healthcare field, which focuses on healing, has an important role to play. We must commit to ensuring that all people, regardless of background or zip code, have equitable access to the highest quality of care. The time has come for America to stop talking about it and start doing something about it. And that's what this executive forum is all about. Today, we'll hear 3 different panels of experts discuss disparities in healthcare and ways to close the gaps. First, we'll hear some of the outstanding progress made by key healthcare systems in eliminating disparities of care. And I have the privilege of moderating that one. Next, we'll highlight examples or case studies of award-winning strategies and programs that have been effective in this area. That discussion will be led by Colleen Santa Anna of Centara Healthcare, the chair of our Equity of Care Award Committee. Finally, we'll conclude with a better understanding of the strategies that advance health equity from a leadership perspective. So let's get started. Our first panel features two healthcare leaders at the forefront of the field's efforts to reduce disparities and increase diversity and inclusion. Earlier this year, the AHA Board of Trustees voted to honor them for their work in this critical area by naming them the 2020 recipients of the AHA Board of Trustees Award. Now, traditionally, this award would have been given during the April meeting of our AHA annual membership meeting here in Washington, D.C. However, we all know that everything changed back in March, so it's particularly fitting to honor them virtually at this executive forum dedicated to advancing health equity and eliminating disparities. It is a pleasure to recognize the leadership and work of Nympha Saunders and Nicholas Tejada, two individuals who have been architects of the association's work on equity and diversity. For those of you who don't already know Dr. Nympha Saunders, she recently retired as CEO of Napton Health, based in Macon, Georgia, capping more than 40 years in hospital administration and caring for patients. And I want to quote from her award citation. A champion for diversity and health equity, Nympha Saunders has made an indelible mark on the American Hospital Association's work to address these priorities. As chair of the Institute for Diversity, she skillfully led the integration of equity of care into the Institute's work as it transformed to the Institute for Diversity and Health Equity. She also guided the Institute to adopt a new business model to make its resources accessible to the entire membership. As chair of the Equity of Care Award Committee, she made certain that the association was providing the field with best practices for successfully identifying and addressing equity issues in communities. In recognition of her contribution and leadership at the AHA, the American Hospital Association is pleased to present its Board of Trustees Award to Nympha Saunders. Nympha has been a staunch champion for diversity and equity throughout her career. Her passion to create a more diverse and equitable healthcare field sets a high bar for others to follow as we continue to advance health equity, diversity, and inclusion. Nympha, congratulations on receiving this award, and congratulations on your well-earned retirement. Nicholas, or Nico Tejada, currently serves as Group CEO of the Hospitals of Providence in El Paso, Texas. That's part of the Tenet healthcare system. As we all know, El Paso has recently experienced one of the most challenging surges of COVID-19 in the nation. He and his team have worked tirelessly to care for patients and protect the community he serves. On behalf of the AHA board, we're honoring him today for his contributions and leadership to the association and the entire field. To quote from his citation, a leader on the front lines of diversity and equity of care, Nicholas Tejada has shaped the American Hospital Association's work on these challenges. As chair of the Institute for Diversity and Health Equity, he set the strategic direction for our new Equity of Care initiative that builds on the work of the field and moves from creating awareness to spurring action. A skilled coalition builder, he has brought together stakeholders to address diversity, inclusion, and health equity. Known for providing inspiration and hope, you may recall his leadership in providing comfort and support to patients and families after a recent shooting in El Paso. He also organized the very memorable immersion experience for the Institute's board that I was honored to be a part of, to shine a light on the impact of health issues at our southern border with Mexico and El Paso's sister city of Juarez. In recognition of his contributions and leadership to the AHA, the American Hospital Association is pleased to present its Board of Trustees Award to Nicholas Tejada. Nico will also begin a term on the AHA Board of Trustees on January 1st of 2021. Nico, congratulations and thank you for all you've done. And we look forward to having you at the AHA board table. On a personal note, it's a real privilege for me to present these awards because both Nympha and Nico have not only been role models and a source of inspiration for me, but they've also been good friends. So now let's get started with the first session of the day, Advancing Health Equity, a Strategic Priority. Nympha and Nico, thank you for being a part of this forum. And again, congratulations on receiving those awards. Nico, let's start with you. How has the COVID-19 pandemic further accelerated the work on equity?
Thanks, Rick. And of course, before I begin, I'd be remiss if I didn't say thank you for that wonderful introduction and for the award. My wife and I were talking the other day about all the different steps that have gone on over the last 10, 15 years as a part of the effort on our side, and thinking about all the people, everyone who invited us to play a part. So the award is special, but it's even more special to share the stage today with Dr. Saunders. She's incredible. I think the world of her. So thank you for that. On the COVID-19, so you hit it right on the head, Rick, when you mentioned earlier that it is disproportionately impacting African-American population, Hispanic population, Native American population. And we're seeing that here in El Paso. Before COVID, we already knew that El Paso had half as many physicians as the national average. We already had those access issues and everything that goes with it. Plus, we have the binational unique challenges that come with being a sister city with Juarez. So we know that cases were going to be more. Recent data, though, from the CDC revealed something even more striking, and that is that 4.2 times more likely, Hispanics are 4.2 times more likely to be hospitalized than non-Hispanic whites, 4.2 times. When you put those two together, it's clear to see why we've had such a surge here in El Paso. So for us, the challenge has been striking to address it, because we already baked in equity to a lot of the things we did. This has really made us exercise our muscle of data analysis to determine which populations were being impacted disproportionate, not just based on race or ethnicity, but age and gender, zip code. We had to look at those areas, and we still look at those on a weekly basis. That helps shape our efforts on education and outreach. It goes without saying that everything we do here is in English and Spanish, but even within the generations that are impacted of Hispanics, you message it differently. And then, of course, within the hospital, we've had to significantly adjust our operations. We all know how visitation's limited across the country because of this, but culturally, that's even more challenging in a Hispanic population where you're used to large families coming in for all types of procedures and experiences. So these are some of the things we've had to adjust to because of the COVID-19 impact is still ongoing. My hat is off to all the team here for what they're doing.
Thanks, Nico. Nympha, what's your take on same question? How has COVID-19 further accelerated the work on equity in your area?
Absolutely. First, let me just thank you for the honor that you've afforded me. I am just so privileged by that. And the organization is equally privileged. But then again, to share it with Nico, how much better can that be? So it's just absolutely awesome. You know, when we started COVID and we decided that there is this COVID normal, we really were not thinking that there were any disparities going on until around March or April, when we started looking at empirical information and started looking at the data. It became evident that there's incredible disparity in the mortality rate, the length of stay, and the complications associated with those admitted. And so what happened as a result of that is an incredible awareness. When you are in a COVID situation, everything is monolithic. You don't have all these other diagnoses that you have. You're very focused just on COVID. So because of that orientation, you've begun to stratify the type of patients that you're seeing. And then it went from stratification to awareness to an alarmness. And we then realized very quickly that we have to do something in terms of access for testing. Number two, immediate orientation of the community. And third, coming up with alternative options for them to be able to access healthcare and testing in a big way. We had a disseminated testing program. We had them in the most compromised community. We knew that there were 15 zip codes that we had to be worried about. And we took healthcare and health to them, and we gave them access as expediently as possible. We also had a mobile unit that allowed us to be able to have mobile education, mobile testing, and also the ability to try to access people. They were concerned about whether or not this is something they're going to have to pay for. So we had to be very pointed and very prescriptive about our approach, but very gentle in our ability to manage them. So the confluence of being internally focused, but also externally oriented to the new needs of these patients, by bringing healthcare to them and taking the fear factor and replace it with a knowledge base that allows them to be a little bit more oriented to the right path, really got us to the right place. But at the end of the day, we went from normalized approach, business as usual, but monolithic group of patients, to acceleration to really absolutely minimize the number of exacerbated cases that we were seeing.
Let me take it in another direction here and ask you both to respond to this question. Well, both of you and your organizations have been at this for a while. Can you share with people the biggest challenges that you faced in this journey and where, you might have stumbled and people can learn from those experiences? Nico, you want to go first?
Yeah, let me jump in there. That's a great question. We've stumbled a lot. I've stumbled a lot personally, and in organizations, it's tough to get traction sometimes on this. Thinking about it just with this group, I think the biggest challenge has been to message it correctly. We all know the different tactics that are involved, but like we all know, almost every problem that we have is based on communication. And to be more specific, I'm sure everybody watching this video has seen the emails come out about compliance training, about legal training, about new policies. I think we've done the same thing, and certainly we have in the past, about cultural competency or things like that, where in essence, we make it about the how we do what we do, when in fact we should have always said, this is just what we do, and integrate it into the messages that talk about readmissions, integrate it into the conversations about infection rates, about business development opportunities. Instead, we make it this separate communication line that makes it separate and distinct from what we're actually integrating into what we do. So to me, that realization occurred to me quite some time ago, but it was a big stumbling block for us to get traction.
Nympha, what's your take on that?
I think Miko is right on point. So when I approach a situation, and when anybody approaches a particular situation, the first thing you really try to discern is this situation looking for a solution that's incremental? Is it looking for a solution that's exponential? Or is it looking for a solution that's opportunistic? Sometimes my signals are crossed, and I try to deal with an opportunistic opportunity with an incremental approach. Or I would try to deal with an exponential situation that gets to the right message in an incremental way, and so then I lose the momentum that's required. So most of the mistakes I've made has been really focused on, am I reading this correctly? Sometimes you have a preformed agenda in your mind, and it's nothing wrong with that, because that's the level of preparedness that you're going after. But sometimes honing into whether it's incremental approach, exponential, or opportunistic is where I get really in a bind. And so correction and the ability to pivot has always been the one thing that I try to train myself to respond appropriately so that nothing is lost. The one that I probably don't do as well is opportunistic situation, where I could have really taken that and said, this is what I'm going to do. But sometimes there's this internal messaging conflict going on in your mind. And by the time you realize it was opportunistic, the opportunity is gone.
Those are really great insights. Nico, how have, culture is always so important. And when it comes to diversity and inclusion and dealing with disparities, creating a culture within an organization is just, paramount. How have you built the culture and the partnerships, both internally and externally, in your community to address health disparities?
Yeah, you're right. It does require internal and external. On the internal side, I spoke to one piece already, just like the messaging and how important that is. So I won't belabor that point. But then there's another piece to it. Too often we think of achieving equity as this grand vision where all of our metrics are going to come together at the same time and everyone will see us as this equitable organization that's achieved success. When in fact, it's small wins. It's a department director that introduced a new approach to care in their unit at one of my hospitals. Well, that needs to be celebrated. That needs to be celebrated for all the reasons that it is, not just that it's equitable, but that it led to a good patient outcome, that it had led to patient satisfaction and safety. These are the things that we need to celebrate. So that's how you build internal culture beyond the massive efforts that we all know and do. And we should continue to do the big efforts, but we have to celebrate the small wins. If I look at the external piece, and that's where I spend a lot of my time, this is where you look at the social determinants of health and the reasons we have inequity to begin with. You look at education. I and other members of my leadership team sit on the committees and boards in the community to narrow the gap in educational disparities that exist in our community. If you look at job creation, another issue, social determinants, we attempt to sit on those committees, on those boards, and help drive that forward in our community. As you do those two things, you actually start to impact things outside the four walls of the hospital in a meaningful way, without necessarily having to be seen as the healthcare expert. You're a community expert, and that helps integrate the two efforts together. So the community, by definition, is helping the journey towards equity.
Gotcha. Nympha, how did you prioritize health equity within your organization, and what resource needs and compelling messages did you use to keep your teams engaged?
So immediately after I got involved with AHA, Institute for Diversity, the first thing in my mind is, how do I translate this? This has got to be real. And the first place I need to translate this is the organization. Shortly after I started conceiving what the concept might be and how I would implement it, I decided that this is really not about me. This has got to be about the organization. And that this cannot be a project. So if this is going to be an organizational priority, I must be able to translate that priority in such a fashion that there's a groundswell among all the employees, among all the teammates, among the community partners, the board, and all of management. So in putting that construct, having had the privilege of being part of developing the equity 1, 2, 3, and eventually 1, 2, 3, 4, I thought, let me do two things. Let me do a groundswell, and then let me put a structure that magnifies this 1, 2, 3, 4 commitment. And that's exactly how we started. And by doing that, we were able to develop a foundation. We were able to get a translation that had a value proposition for the community, the patients, as well as our teammates. The patients were aware of what we were doing in terms of the 1, 2, 3, 4 pledge. We started with the 1, 2, 3, and then converted to the 1, 2, 3, 4. And then we started to integrate this into everything that we did. It was not a project. It was not something that we said, well, we will measure this on a monthly basis. We just said, this has got to be a way of life. What is really incredible about this is after we grounded it the first 3 years, our next focus was how do we keep ourselves relevant as an organization and sustainable with this fully integrated project? Well, about that time, we're joining Atrium, and of course, Jean was the leader of the 1, 2, 3, and so it was phenomenal to work with Jean and allow us to translate not only from a local foundation, but get it from a bigger systemness, and the resources associated with the local domain, the resources that Atrium was able to provide us really anchor this. And then we started to look at our mission, our vision, and our values, and we made sure that every focus that is an organizational mission and values and goals were very integrated to what we said we were going to do. It was not delineated as a project. It was just a way of life.
Yeah, I think the real key message there, I think, is baking things into the DNA of the organization.
Exactly.
Let me ask you both to respond to this question. When we talk about health equity, disparities, inclusion, there are sort of two things, but they're totally interrelated. There's the issue of disparities and inequities in the delivery of care. And then there's the issue of diversity and inclusion when it comes to leadership. So what would you say are the top three strategies that you think are best when it comes to the question of diversity in leadership and inclusion into leadership? What's been the three most successful approaches that you've taken to address that side of the equation? Nico?
Sure. That's a really good question, a very important topic to me. I wish I could tell you all the wisdom that I learned on my own, but I learned it from other people who have lived it, not the least of which is Tom Zenti, who we all know have been very involved with the AHA. I remember I asked him more or less this question at some point in the past, and he was very clear, as Tom tends to be, and very knowledgeable. He said very easily, promote from within. When looking to increase diversity in your organization, realize that it's right in front of you. If you want to match what your community looks like, what they behave like, what they think like, it's on your team already. So that's number one. Aim to promote from within. To do that, of course, you have to have critical reviews. You have to have transparent feedback, like you would with any employees. But you have to make a focused effort to do that with the people who are on the front lines. What we often see is, yes, it's easy to promote from within to the director type level. It's a little bit harder to promote from within from the director to the chief level. And that's where you have to have that deliberate review process with the intention of, again, promoting from within. The third thing I would say is you need to do whatever you can to promote those individuals' visibility on a larger stage. The AHA, of course, is an obvious example. They have done wonders for many people to give them a national platform or a regional platform to show what they can do. But even at a local level, putting individuals forward makes themselves see themselves as leaders, which is unique, and they don't always get that opportunity. Those are the things we've attempted to do here in El Paso. I'm very proud to say, I just counted it up, and of the last 8 executives we've hired into chief positions, 6 of them were born and raised in El Paso and echo the demographic that's here. So we're very happy about that. It gives our organization much longer runway to success.
Great advice. Nympha?
So there are 3 things that come to mind. Number 1 is what I call competency. Is there a strategic competency within the organization that could really drive this as part of what we do every day? The other one is the operational competency. Can they actually convert what you want to do and what you're thinking from a strategy standpoint into an operational, executionable type of competency? And then the last one is the people competency. And this is where the cultural competency, the ability to advance people that Nico was talking about, is really important. You can't just say you believe in this, but then there's no evidence. Evidence-based is always going to be where people are going to go back to, that you're actually developing the competencies. And then second, other than competencies, are we role modeling this? Is it really alive? Does it have a life? Is it palpable in the organization? And then lastly, the whole concept of accountability. If you thought about it, you said it is important, can you actually do it? And does the measurement actually go back to what you said you were going to do? Were you able to pivot when you needed to pivot? But at the end, success is measured by an incredible level of accountability towards consistency.
It's sort of a cliche when we talk about how addressing diversity and inclusion and eliminating barriers to disparities and creating health equity. It's a cliche to say that it's the right thing to do, and that but it's also there's business reasons to doing it. And in addition to doing the right thing, it's also smart business. You think about how consumerism and the patient care experience is front and center in this day and age. And hey, if you're not taking into account the different aspects of diversity, you're not going to create a good patient care experience. And then there's the payment pieces where, there are either incentives or disincentives. I mean, we know that HCAHPS, the consumer, ratings, that's related to creating a good patient care experience. Readmission penalties, a lot of that is related to dealing with the social determinants of health, which get to the core of this. So I guess my question again to both of you is, how do you make the business case for why this is important, stipulating it's all the right thing to do? Nico?
Yeah, so I'll tell you a very quick story, and I think I might even have said this on a different stage with Dr. Saunders many years ago. I'm getting older. Anyways, so I often tell the story when I give presentations on this. I ask the crowd to think of what a tugboat captain looks like, a tugboat captain. And inevitably, I get more or less the vision of Santa Claus, right? So that's what it looks like to the audience. Fine, it's normal heuristics, people do that. Then I asked them, the crowd, to tell me, what do you think the compliances of that person is to their healthcare regimen? And they always say, well, they're probably not a compliant patient, probably smoke, probably drink, etc. Perfectly normal to have those assumptions. But let's say you are a nurse on the nursing floor, you have 4 patients to discharge, and it's 30 minutes until you're supposed to go home and be with your family, pick up your kids, whatever you have to do. You're looking at the 4 patients you have to discharge, and there's one who's a tugboat captain. And you think the same thing, probably not a compliant patient. I'm going to shortcut the discharge instructions because they probably won't listen to me anyways. And sure enough, you shortcut the discharge instructions, the person becomes a readmission later. All of those happen because the natural biases that exist. This is why that one example can happen every day in each of our hospitals. This is why you need a group of people working in the organization who can connect to the tugboat captain, so to speak, or to any other type of person who lives in your community, because you don't make assumptions. You understand where they're coming from and their incentives and motivations. To me, that touches on clinical, because obviously readmissions, but then also helps you understand your community. And I often ask the people in the crowd, tell me about the community you serve. And inevitably, people come back and give me the demographic of their city, when in fact I'm asking, what about the patients who come through your doors? And the reason I ask that gets to the business case. If someone tells me that they have a 40% Hispanic population, and then they tell me they have 30% who come through their doors, well, that's a 10% opportunity there. Based on the service you provide, you have an opportunity to go increase market share, increase the level of care and caliber of service you provide to that population that can earn their trust. So I kind of try to weave in those stories as I make the case.
Great story there.
Thanks.
Nicola, how do you make the business case?
So I'm going to give you 3 pivotal points that are always top of mind and should be top of mind for everyone. Number 1, there's no equity without diversity. So that's really important to remember as a principle. Number 2, we're moving from healthcare to health. That's what we're focused on. If you only see 10 or 15% of the population, that's not health. So you're going to have to get out of your walls and begin to really know your community and the population you serve. And number 3, given the preponderance of issues related to the social determinants, we're going to have to really focus on what that is, how do we deal with this, and so forth and so on. So if I use that as a foundation, it seems to me that the business model of the organization is the same as the business case for everything that we do. I don't think we should have one channel for equity and diversity as a business case and another channel for the business model for the organization. The corporate model, the corporate business model, the clinical professional business model, the social business model must be one and the same. And when we translate that to the community, we must be convincing that they are interwoven, they're intertwined, and to separate them would break the whole mission, vision, and values of the organization. So to me, they really are all woven into one, so that the business case of anything that we do must be the business model for the organization at any point in time or at any segment of the organization.
Gotcha. Hey, and before we close, let me just ask each of you, what question haven't I asked that you'd like to answer? Nico?
Well, we always talk about what are the things you can actually do, right? Leaving this meeting, what can you do? So I'm going to ask, well, let me put it this way. I love the idea of drawing. I wish I was someone who's a good artist. I'm not. I'm reading a book on Da Vinci right now. I'm envious of what he was able to do. I've read studies, and clearly the hardest part of drawing, being an artist, is not choosing which pen or paint. Rather, the hardest part of drawing is the ability to see the shadows, to see the different Pantones that exist in front of you. Similarly, it's impossible to really pursue this effort for equity or diversity unless you know your organization, unless you see the numbers, unless you pursue the numbers. And that's where we talk about collecting data, race, ethnicity, language, etc. Collecting that information and stratifying it in your organization. It was true before COVID. It's even more true with COVID. So I would just ask people, taking away here is find one small win you can get in your organization and pursue it.
Gotcha. Nympha, closing thoughts?
I guess the question I would ask is there a different multi-generational approach? Today, for the first time, we have 5 generations. We have the Gen Z, the Millennial, the Gen X, we've got the younger Medicare or the baby boomer, and then we have the older Medicare. Is the one-size-fits-all approach really the right approach? Or is there something that we can learn from the Gen Z and the Millennial who are very agnostic to all these divisions? It seems to me that if we can reverse this pyramid and say, hey, what do you think we're doing? Internal conscious and unconscious bias in here because of a generational difference? Or is it just a national challenge? So that would be the question I would ask, and a challenge I would put out there to say, it may not be a one-size-fits-all, but would the orientation and the accommodation be different?
Boy, and that really leaves us with so much hope for the future, because I know I experienced that firsthand with my millennial children and my grandchildren. They live in a different world, and it's wonderful that they don't see it in the divisions that we see it, and that's what I know gives me hope for the future. And in some ways, it's also important to recognize that a lot of that, frankly, not to toot my horn or anybody's, but it starts in the family. It starts at the dinner table, and that's something that I think we all have to always keep in mind as well. Nympha and Nico, thank you for sharing your insights, and thanks for your leadership and your commitment to this critical issue. Clearly, one of the big takeaways from these two leaders is commitment. Making real progress in addressing health equity must be an organizational commitment, from time and energy to having the right resources and support. Culture change is not easy, and it's not fast, but with committed leaders like Nico and Nympha and all of you, we're going to get there. Now more than ever, we must recommit to address healthcare disparities. Now more than ever, we must harness the collective power to champion changes that will advance health for every American. I know we can and we will make a difference.